Welcome to this explainer. You know, we've all been there. Waking up, swallowing, and suddenly realizing your throat feels like it's literally lined with sandpaper. Well, today, we're going to become medical detectives. We are peeling back the curtain to see exactly how clinicians evaluate a sore throat. Consider this your insider's guide to medical triage, where we figure out exactly what your body is trying to tell you. Let's be totally honest for a second. When you are experiencing that miserable universal pain of a severe sore throat, when swallowing hurts, speaking hurts, even breathing hurts, your natural immediate urge is probably to march straight into a clinic and demand a prescription. But as we're going to explore, the medical reality of what will actually cure that pain might completely surprise you. So here's our game plan for today. We'll start by tackling the antibiotic myth, show you how doctors score your symptoms, walk through checking your own tonsils, highlight the urgent red flags you simply can't ignore, and finally cover what it means when your symptoms just won't go away. All right, let's jump right into part 1, the antibiotic myth. 1 week. That is the magic number here. The vast majority of acute sore throats, they're caused by viruses, not bacteria. And here's the kicker. Whether you take antibiotics or do absolutely nothing, a viral sore throat is going to pack up and leave on its own in about 7 days. The official medical guidelines in the UK, known as NICE guidelines, are actually built around sniffing out the rare bacterial cases that do need a prescription rather than just throwing antibiotics at everyone. Moving on to part 2, scoring your sore throat. So how do doctors actually figure out who gets the meds? They play detective using scoring systems. First up is the Centaur criteria. You get 1 point each for pus on the tonsils, swollen glands at the front of your neck, a fever over 38 degrees Celsius, and this is a big one, the absence of a cough. Then there's the fever pain score, highly recommended in UK primary care. It looks for a fever in the past 24 hours, purulence, which is just a fancy word for pus, attending the clinic rapidly within 3 days, severely inflamed tonsils, and again, no cough or cold symptoms. Now, this perfectly explains why your doctor might be holding back on that prescription. Even if you hit a high center score, say 3 or 4 out of 4, you still only have a 30 to 60% chance that a streptococcal bacteria is actually causing your misery. That means there's up to a 70% chance it's still just a stubborn virus. But watch how those odds shift with the fever pain criteria. If you rack up a 4 or 5 out of 5 here, suddenly you're looking at a 60 to 65% chance of a bacterial infection. This is the exact tipping point where a clinician is highly likely to say, okay, let's start immediate antibiotics, usually something like phenomethyl-penicillin. At this high score, the medication is actually likely to shorten the duration of your symptoms.
Which brings us to part 3, checking your own tonsils.
You know, you don't actually have to sit in a waiting room to find these visual clues. You can do this 3-step physical check right at home. Step 1, grab a good flashlight or stand in some really bright light with a mirror. Step 2, gently say, ah. This naturally drops your tongue out of the way. Step 3, look right at the back of your throat, at those 2 tonsils on either side. Being able to accurately report what you see there is an absolute game changer for speeding up a phone or video consult. So, what are you actually looking for? Well, if you see just redness and swelling, it's way more commonly a viral cause. But if you spot exudate, which looks like white, yellow, or grayish patches or little spots of pus sitting right on the tonsil surface, that points toward bacteria. Spotting that pus is the single visual sign most linked to a bacterial cause, and your biggest indicator that you might actually be offered antibiotics.
Let's shift gears now for part 4, urgent red flags.
We are moving away from your run-of-the-mill sore throats now and into the rare, dangerous medical emergencies. These are the red flags you absolutely cannot ignore. First up is quinsy, clinically known as a peritonsillar abscess. This is a really nasty complication that usually pops up from untreated or worsening tonsillitis. Basically, a pocket of pus collects directly beside the tonsil. It's a severe, localized infection, and unfortunately, standard oral antibiotics alone just aren't going to cut it here. So, how do you spot quinsy? The symptoms are pretty distinct. The pain is usually severe and heavily concentrated on just one side. You might get trismus, which is a medical term for literally struggling to open your mouth all the way. You might also have what doctors actually call a hot potato voice. You sound muffled, like you literally have a hot potato stuck in the back of your throat. Your uvula, that little dangly thing back there, could be pushed way over to one side, and you might even find yourself drooling because swallowing is just too agonizing. Here is the absolute bottom line. If you have these symptoms, you need a same-day assessment. No exceptions. We're talking an urgent ENT or emergency department visit because quinsy almost always requires physical drainage of the abscess along with IV antibiotics. It is absolutely not a wait-and-see scenario. Now, as scary as quinsy is, epiglottitis is an even more critical, rapidly escalating emergency. It is a rare but incredibly serious infection that threatens your actual airway. While we mostly see it in unvaccinated kids, make no mistake, it certainly happens in adults too.
The symptoms here are terrifying because they escalate fast. We're talking a super rapid onset with a high fever. The massive warning sign to listen for is stridor. That's a noisy, high-pitched breathing sound, especially when lying flat. The person will usually be drooling, entirely unable to swallow, and naturally lean forward on their arms just to keep their airway open. And please, listen carefully. If you suspect this, never, ever try to examine the throat with a tongue depressor or anything else. It can literally cause the airway to completely close off.
If you even suspect epiglottitis, you must call 999 or head straight to A&E immediately. This is a drop-everything absolute emergency, not something to try and schedule a routine GP appointment for.
Okay, let's take a breath and look at part 5, when symptoms persist.
Stepping back from the immediate emergencies, let's talk timelines. Most standard sore throats clear up within 1 to 2 weeks, but the magic threshold you really need to remember is 3 weeks. If your symptoms hang around past that 3-week mark, especially if you're an adult over 45 who smokes or drinks heavily, that triggers the NICE threshold for an urgent 2-week wait head and neck cancer assessment. What exactly are doctors looking for after 3 weeks? They're watching for unexplained hoarseness, mysterious ulcers in your mouth or throat, any new or persistent lumps in your neck, pain when swallowing that just won't quit, or unexplained weight loss alongside those throat symptoms. Now, I really want to emphasize this and reassure you, most of the time, these cases turn out to be completely benign, but they do meet the medical guidelines for an urgent specialist referral, just so doctors can safely rule out cancer.
Finally, part 6, wait and see or emergency. Let's bring this whole thing together. We've essentially got 4 distinct pathways of care here. Routine contact with your GP or pharmacy, that's for when you've got a fever, visible exudate, or a high fever pain score. Same-day assessment is mandatory if you have severe one-sided pain, a muffled voice, or trismus. That points straight to quinsy. True drop-everything emergencies, that's noisy breathing, stridor, and drooling, which screams epiglottitis. And lastly, the urgent referral pathway kicks in for any unexplained symptoms dragging on for more than 3 weeks.
So I have to ask, are you ready to triage your next sore throat? Knowing these clinical signs isn't just about satisfying curiosity. It is absolutely about empowering yourself to safely and efficiently manage your own health. The next time you wake up with that awful, scratchy throat, will you immediately demand an antibiotic, or will you grab a mirror, check for that exudate, and follow the clinical evidence? Thank you so much for joining me for this explainer. Keep asking questions, stay curious, and I'll catch you on the next one.